Privilege and honor to introduce our first presenter, Ambassador Eric Goosby, who is the head of the Global AIDS Program and PEPFAR in the Department of State. Eric.
Thank you, Bob. It's really an honor to be with all of you here today. I really want to acknowledge the second International HIV Treatment as a Prevention Workshop meeting. The hosts and organizers at the BC Center for Excellence in HIV/AIDS have had a long period of working with this disease and have contributed on multiple levels. This is certainly one of your central contributions. It is always wonderful to be in this beautiful city. Coming in this morning, I had to pause to remind myself how beautiful it is. So it's always a pleasure to be back here. It really has been since the Vancouver meeting that I have been. I haven't been here since the Vancouver meeting so many years ago. So it's wonderful to be back. I want to specifically thank the co-hosts, the International AIDS Society, the United Nations AIDS programs, the WHO, the National Institute on Drug Abuse for their contributions to this meeting. I think a critical and timely discussion of the role that treatment plays in prevention. But I specifically want to thank Julio and Ellie for the co-host, co-chair roles that they've played, two friends and colleagues for many years, and it's really an honor to be asked by them to speak to you tonight. The organization of last year's workshop was timely. As Julio said, just days before the results of the groundbreaking HPTN-052 study that we have all reacted to and thought about so much in this past year. The report of the workshop was presented at the IAS conference in Rome last July. Many of the concepts outlined in the first workshop form the basis for productive discussions globally and were key inputs in the formulation of WHO guidance and PEPFAR policy over the course of the last 12 months. As you know, at the very highest level, the United States government has embraced the importance of treatment not only as a critical tool for decreasing morbidity and mortality, but also perhaps the essential tool of prevention and the achievement of an AIDS-free generation. Today, we are again privileged to sit at the intersection where the worlds of science and implementation combine to produce significant public health impact. This link between knowledge, generation, and rapid deployment of evidence-based interventions makes for a powerful combination. With treatment as a critical component of combination prevention, we now have the tools to bring us closer to an AIDS-free generation. This is the end game. And in this endeavor, you as clinicians, scientists, and modelers are all critical partners with our implementing countries' leadership, including civil society, to move this agenda forward. Today, briefly, I'll address how PEPFAR is building on the scientific foundation in combination prevention and work toward an AIDS-free generation, a goal that would have been unthinkable even several years ago. I'll also focus my talk on PEPFAR's approach to treatment. I'll touch on the other elements of our combination prevention approach, including the prevention of mother-to-child transmission and voluntary male circumcision. Let me begin by focusing on treatment. In terms of global implementation, PEPFAR has taken this intervention, once thought to be possible only in developed settings, high-income country settings, and successfully deployed it in over 38 countries to scale. In 2003, only about 50,000 people in sub-Saharan Africa were receiving treatment. Today, PEPFAR supports over 4.3 million on treatment globally, the vast majority of whom are in sub-Saharan Africa. Building on the strong foundation laid under the Bush administration, the Obama administration has increased the number of people directly supported on treatment since taking office by 127%. The effects of an individual receiving treatment are profound, of course. I won't outline those clinical manifestations. However, a Stanford study a few years back with PEPFAR 1 demonstrated that over 1 million deaths were averted in the first 4 years of PEPFAR, a number we expect has at least doubled since that time. Studies have also shown that treatment, by keeping parents alive, also has tremendous effects on families. Recent estimates from CDC, with John Blanford's work, suggest that for every 1,000 people we support on treatment for 1 year, we avert the orphanhood of 449 children. 449 children. That is another important dimension of the concept of treatment as prevention that we should not forget and should factor in. Because of this, the potentials that are not lost and the lives that are more fully realized are extraordinary and continue with that one individual that we pull back and preserve their life. They in turn affect all those around them, and it continues to ripple out for the family, the community, and the country. It's also helpful to look at the costs averted by treatment. For example, the averted lifetime care and treatment costs for a recently infected individual. Through this lens, the CDC, again with John Blanford's work, estimates that the cost per additional life year gained drops to about $175. That's an extraordinary drop. In the time I've been in PEPFAR, we've gone from $1,200 per person per year down to the $175, a remarkable, breathtaking saving of resources. When you add this to the productivity gains, a recent study of the Global Fund found that the cost of treatment programs shown below the line were actually outweighed by the societal economic benefits shown above the line. So how has our program responded to the extraordinary data from HPTN 052 and increasing evidence of broader societal benefits of treatment? One of our first actions was to quickly hold a series of internal U.S. government meetings and to convene over 50-member PEPFAR Scientific Advisory Board and to think through with our colleagues at WHO and UNAIDS, and in many areas with data that we were able to glean or put together with the Gates Foundation and CHI, the Clinton Foundation, we were able to put together a picture that showed us that this was the moment in which we must act, and as Tony Fauci said, let the data lead the way, to take the leap, to accept this data, and move with it with the proviso that we understand in as real time as we can the nuances in implementing these programs to maximize impact and to be willing to change our programmatic model to achieve that. We were in a similar position in 1994 when the first data came in for the antiretroviral drugs ritonavir, saquinavir. We were given this data in the Department of Health and Human Services and had to make a decision as to whether or not we would accept this before definitive data came in to show that indeed lives were going to be turned around, but we didn't know for how long, how durable it was, would it last, etc. But really did have to take the leap to assume it would, be willing to study it in real time, to change it if it didn't. But because of our ability or inability to cover costs, that acknowledgement and recommendation that came out of HHS to use antiretroviral drugs precipitated a cascade of potential funding with insurance companies, et cetera, that allowed this to move forward. As many of you are aware, our PEPFAR Scientific Advisory Board deliberated over the summer and late last fall, sent a series of recommendations to my office. Among these were recommendations to further accelerate treatment access to those under 350, to prioritize early access to treatment to those co-infected with active tuberculosis, to express preference for WHO option B for PMTCT, over option A, to recognize the effect of treatment on transmission, and to support the use of treatment above 350 based on local priorities, programs, and the specifics of the patient interaction. And lastly, to redouble efforts to provide care and treatment to key populations, difficult to reach populations. These recommendations, along with critical internal deliberations, led to Secretary Clinton's speech in November. As she stated, quote, "Now we know beyond a doubt, if we take a comprehensive view of our approach to the pandemic, treatment doesn't take away from prevention. It adds to prevention. So let's end the old debate over treatment versus prevention and embrace treatment as prevention." As Tony Fauci just elaborated in the YouTube, this still reverberates in our community and remains a challenge both within the United States government and in the global dialogue to resolve. This vision, built on our work together, received its most important endorsement by President Obama. On World AIDS Day, as we've already seen, at an event including Presidents Clinton and President Bush and many others, the musical superstar Bono and Alicia Keys both gave their kind of weight to the statement that this was that moment. Among these was an increase in our 2 years in our treatment targets for 50% increase to 6 million people supported on treatment in the next 2 years. Recognizing the extraordinary opportunities that exist with the new tools, the President also noted, as a matter of policy, we're now investing in what works. On a practical level, how are we carrying out this vision? This year, PEPFAR's program's guidance stresses the priority of ART for saving lives and endorses an accelerated scale-up model. It states that as a guideline, we need to spend every dollar mindful of the fact that it could have been used directly to save a life together with antiretroviral treatment. Countries with the highest burdens of disease, with lower levels of treatment coverage, and the lowest internal and dispersed global fund resources were shown here in yellow. These countries were encouraged and expected to consider raising their budgetary allocations to diagnose and treat over time and to set ambitious treatment targets. We've accepted the SAB's recommendations, and my technical and programmatic expertise within OGAC have gone over these issues with each of our country teams. We are now in the middle of that dialogue as our country operating plans are discussed, where country by country, really province by province, we are looking at the expansion of the PEPFAR footprint, how it relates to what the country is currently doing, and how it relates to what the Global Fund is currently doing in country, other bilateral programs, other programs funded by World Bank, by foundations, et cetera, to truly be additive in our ability to use these resources to expand the capacity and not to parallel expand the capacity. In particular, we will work intensively with countries to ensure that they are maintaining and increasing their commitments to the HIV response, not to supplant their resources, particularly their support for interventions grounded in high-impact interventions. Finally, as an implementer, PEPFAR looks to WHO for technical guidance. This week, WHO released guidance on testing, counseling, and treatment for serodiscordant couples regardless of CD4 count, based on HPTN 052 and other studies. PEPFAR truly pleased with this and fully, as you all endorse this guidance. Treatment as prevention in this context is a potential powerful prevention tool and helps address a long-standing need for safer conception among serodiscordant couples. We would like to stress that the use of ART for prevention should be driven by local priorities and context and strategically adopted with prioritization of coverage of those most in need, later stage disease, co-infected with TB, pregnant, also age, as well as just being an HIV-positive newborn infant that would indeed benefit from immediate initiation of antiretroviral therapy. The resource considerations aside, this is what the science says, it's what we should do, and we should work to find the resources to address it. Turning to mother and child transmission in the global context, I'm proud to note that PEPFAR, in partnership with UNAIDS, our WHO colleagues, UN colleagues, have created an expectation that we will be able to address the 390,000 children who are born annually in the world, HIV positive, with a strengthening exercise in our PMTCT programs. In 2011 alone, PEPFAR tested nearly 10 million pregnant women. Of these, we found 660,000 pregnant women who are HIV positive, and ARVs for those women were started and allowed for more than 204,000 children, infants, to be born HIV-free. These are the highest PMTC results of any year in PEPFAR's 8-year history. Last June, we launched the global plan towards the elimination of new pediatric infections and keeping mothers alive. The executive director of UNAIDS, Michelle Sidibe, and I have put a process together that has brought our UN colleagues and our private sector colleagues in the business community together in strengthening exercises that are targeted at provincial ministries of health in the 22 countries that make up 97% of the pediatric burden from vertical transmission. The fact that we, at this moment, are in a period where the numbers are small enough for us to truly get our programmatic heads around a strengthened response to drive those numbers down more aggressively. I regret that I will not be able to stay in this meeting. I will leave tomorrow to meet Michelle in Nigeria to really take what for us is a unique dialogue to the President and to his leadership to convene out of the, looking at the states in Nigeria, there are 17 that are really the problem areas and slow starters. We are convening all 17 governors. The President is convening 17 governors. We are supporting the President in that dialogue around what will it take for us to initiate, turn the volume up, invigorate a PMTCT strengthening exercise in all of your states. That effort will be at the diplomatic level. We will address the most senior leadership in Nigeria, but to try with ministers of finance and the Minister of Health, with the National AIDS Committee, to put a plan together that, again, will be state-specific, but will be, we hope, invigorated by the will of the President, pushing his governors to engage more vigorously. On World AIDS Day, President Obama announced a target of 1.5 million women on ARVs to prevent vertical transmission over the next 2 years. Like the treatment goal, these are ambitious targets and represent our contribution to a vigorous global effort that is already well along. We hope that this effort adds that added strengthening attempt to bring it to its full potential. Recently, WHO released really a forward-thinking PMTCT technical update. The document encouraged countries to assess their national guidelines with special attention to operational effectiveness in an effort to improve PMTCT and treatment coverage, as well as the quality of services for pregnant women in resource-limited settings. This guidance provides important operational insights, supporting us in translating clinical trial results into programs that can actually work in resource-limited settings. I know this group is familiar with options A, B, and B+. The new WHO technical update acknowledges that options B and options B+ may prove preferable to option A for operational, programmatic, and strategic reasons in some settings. WHO recognizes that in addition to preventing HIV transmission to the infant, options B and B+ have additional benefit in preventing transmission to an HIV-negative partner in the discordant context, as well as other potential advantages. For these reasons, ministries of health in 10 countries where PEPFAR's portfolios have begun implementing, piloting, or considering option B+. Today, I'd like to announce that PEPFAR fully endorses the WHO technical update. Based on this WHO guidance and on the recommendation of PEPFAR's Scientific Advisory Board, PEPFAR is now updating its programmatic guidance to favor option B+, over option A, and will support countries with the implementation of both. As we roll out these programs, implementation science will play a key role given the limited data on a test and treat approach for pregnant women in resource-limited settings, and challenges with retention of pregnant women in PMTCT and on treatment in these countries. We cannot wait until the studies are done. We will move forward with implementing, but as I've said, we will position ourselves so we understand what we're doing in as real time as we can put it, so we can make those corrections to continue to increase and sustain impact. Treating people living with HIV cannot be our sole approach ever to prevention, and we need to acknowledge the critical interweaving of testing, identification, staging, retention strategies that bring people into care and keep them in care over time. Our ability to acknowledge the behavioral components that change or increase or decrease risks over time can also not be ignored and need to be a central component of the ongoing dialogue we have with our populations to keep them HIV negative. Male circumcision is a critical element of this strategy. Studies have shown this low-cost procedure reduces the risk of female-to-male transmission by more than 60%, and that the benefit is lifelong. Extended follow-up of participants indeed has shown up to 5 years post-trial indicated that the protective effect increases to over 68%. So how are we doing with scaling up circumcision? I don't have to tell the people in this room what a struggle this has been. Since 2007, some 1 million men around the world have been circumcised for HIV prevention. 3/4 of these procedures have been funded by PEPFAR. Most of these circumcisions have happened in the last really 18 months. In 2010 and 2011, PEPFAR funded over 790,000 circumcisions in 14 countries. That's a small percent of the total number needed, but it is a start, and believe me, we have learned that there is an energy threshold of activation that needs to be reached, both within the political context, but also within the community in which you are introducing the option of circumcision before the engagement really gets picked up by the people. It's estimated that 1 HIV infection is averted for every 5 to 15 circumcisions, providing a lifetime benefit, making it a cost-effective intervention. And as HIV prevalence decreases among circumcised men, there's an indirect protective effect that's reflected to the women. Women's uncircumcised male sexual partners and ultimately the whole population, especially over a 10 to 20-year time horizon, will benefit. PEPFAR has invested over $204 million to date to support the approximately 1 million male circumcisions. On World AIDS Day, PEPFAR also committed to an additional 4.7 million circumcisions in the next 2 years. Other elements, now we know that interventions like these can't be successful in isolation. They require strong testing and counseling support and work best when combined with aggressive condom promotion and distribution and other effective prevention interventions on the behavioral modes. And they rely on strong systems and personnel, including trained community health workers. They depend on institutional and social changes like ending stigma, reducing discrimination against women and girls, stopping gender-based violence and exploitation, which continue to put women and girls at higher risk of HIV infection, and repealing laws that drive key populations underground and make it difficult for them to reveal themselves to their family and their medical delivery systems. We also know HIV is a complex pandemic that varies within and between countries. Combination prevention needs to reflect this complexity. When it doesn't work as well. We need to know more about which combinations are more effective in concentrated epidemics and with key populations versus in more generalized. And then we need to rigorously apply that knowledge, taking care that interventions that might be less appropriate for a particular epidemic aren't favored over the most effective and impactful combinations. Under this administration, we are working to ensure that we support countries in responding to local epidemiology and tailoring their programs to key populations, including groups at highest risk. UNAIDS highlighted the potential of these key combination prevention interventions, including treatment, PMTCT, and male circumcision in their investment framework model published in The Lancet last year. They showed that the combination of these high-impact interventions can result in a major reduction in new infection and a bending of the curve of the HIV epidemic. To move forward with science toward an AIDS-free generation, we must acknowledge that AIDS is a shared responsibility, the response, and that shared responsibility must be met by multiple sources. PEPFAR represents a bilateral U.S. contribution to the global responsibility. Yet, we are only one of 3 essential funding sources that really do play out in all of the countries that we are currently in. The second is the other donor investments, including those made through multilateral mechanisms, such as WHO and UNAIDS, the Global Fund, and the country itself is the third. It is also the partner government's role and responsibility to play the convening role of convening the stakeholders in country to define the unmet need, to prioritize that unmet need, and then to make the allocation decisions accordingly. That shift in control of prioritization and allocation is a sea change for the U.S. government's way of doing business, but it is a critical change without which we will not be successful. We have got to accept that the donor relationship to our partner countries has got to mature as we understand our response and the impact that our response generates in each of the specific epidemics that we work in. One country doesn't have one epidemic, it has thousands of epidemics, and it's understanding those nuances that allow us to increase impact and sustain the shift. Together, with country leadership playing this convening and orchestrating role of these divergent funding lines, PEPFAR, Global Fund, Foundation money, World Bank money, WHO, UN resources, as well as the country's resources, can be converged so they are truly additive and not creating parallel systems, that they have looked for opportunities to synergize and cooperate in making one system so we can save those resources to move back into program. That one kind of efficiency of common sense types of decisions has allowed PEPFAR to, in a relatively severe funding period, continue to expand in all fronts, prevention, care, and treatment. And it now becomes apparent to us that that type of thinking, if we apply it to our larger global community of resource, will allow for those opportunities to be realized globally. I believe that hundreds of thousands, if not millions of dollars will be saved in each of our settings if we move to this, if we move to a willingness and an openness to be additive in the way we put our resources on the table. But it requires at its center a convener, and that convener is best placed in country leadership, in public as well as in civil society, and it is nurturing and enhancing the capacity of our partner countries' ability to play that convening and orchestrating role, to manage, oversee, monitor, and evaluate these programs that I believe will move us to the end game. With this set of tools and resources, the global community is now poised to reduce incidence to a level where instead of starting 2 people on treatment for every 3 or 4 new infections, we can reverse that. Indeed, we can reduce the number of newly infected people to below the number of newly eligible for treatment each year, as shown in this slide from UNAIDS. This is the power of joining science and implementation, and of developing policies based on evidence. As Louis Pasteur so aptly said, science knows no country because knowledge belongs to humanity, and it is the torch which illuminates the world. I believe that we, in being the instruments that define, correct, connect, identify the critical questions that are out there to increase our impact, to amplify our response, to make our response additive in countries. You all in this room are those individuals who define those critical questions. It's not just any question, it's the critical questions. Does the research that we do answer those questions? And if the answers come forward, as they had in HPT N052, do we move to implement them to scale? Or do we continue to identify sub-problems that immobilize our ability to move forward? Not to ignore those problems or to not answer those sub-issues or those population-specific barriers. They are critical to answer, but to have the courage to take the step to implement programs and be willing, as we've said now repeatedly, to modify our implementation in real time as we move forward and have the willingness to dismantle and reconstruct. It is truly an honor that we find ourselves at this moment together. It is truly my honor to be here with you at this moment as we move forward in what I hope defines a new response to the morbidity and mortality on our planet that allows us to start to talk about abasement of health care for all people, regardless of being born in a resource-rich or a resource-poor setting. That ability to access and be retained in care become the human right that it is, and that we as donor community and as the global community position those issues and honor that human right component to health care in all the work we do. I want to thank you for the work you do and commit to you that we hope that the next few years that we move through together will really show us that bright light at the end of the tunnel that the data over the last 12 months has raised in front of us. So I thank you very much.